Welcome, Dr. Sandeep, to Wednesday Academics. This is a weekly session which we do with us. Dr. Sandeep is a good friend of mine. We've been associated together for more than 15 years, I presume, maybe more. Dr. Sandeep is currently working in Cytecare Hospital as part of pain and palliative team. He has traveled across the country and brought and gained significant experience and expertise in pain and palliation. So requested Sandeep to talk about palliation and end of life, and kindly agreed to talk about it. So over to you, Sandeep, and thanks for doing this.
Am I audible?
Yes, you are.
Yes, you are.
Thank you, Lokesh, for introducing. It's been honor and pleasure to be part of this learning session. So today I will be doing on end-of-life care and managing actively dying patients. I'm sorry, I'm stuck here. I think I'm not able to change my slide.
Do you want to stop and represent?
Yeah, I'll just want to stop. Sorry for the delay. So end-of-life care and management of actively dying patients. So I think we all deal with similar patients in ICU, critical, those who are almost close to dying. Some of them, they recover and they get back to normal life. But then some of them, they deteriorate further and they die. But then, what we do in palliative and what we do, what you people do as intensivists and critical care specialists is different, because the goal of care is different. The principles involved in the care are different. So it's a quote, I got it online. It's most people plan for the future, but very few plan the end. But then, end is very important, right? So let's begin with a few definitions. So terminal illness, what is terminal illness? An irreversible or incurable disease, conditions from which death is expected, or it's going to happen in future, definitely. Actually dying, it is hours to days before the imminent death, during which time patients, all the physiological functions, there's organ failure, there's multi-organ failure, and slowly the functions deteriorate and they wane. CPR, you're experts in that. So it's an emergency medical procedure, combines with compression and artificial ventilation. So DNR is, is a procedure now, actually. So decision documented not to initiate or perform CPR. Palliative care, it is the holistic approach to treat and improve the quality of life of the patients, and not just the patient and the families, those who are facing life-threatening illness. Initially, it was only to cancer care, but then now it is extended to even other illnesses, non-cancer also. So end-of-life care, this is what I'll be covering today. An approach to terminal ill patients that shifts the focus of care from symptom control, comfort, dignity, and quality of life. And quality of dying also is involved in this, rather than treatment aimed at cure and prolongation of life.
Sandeep,
Dr. Sandeep, yeah, sorry. Yeah.
We finished end-of-life care. Palliative sedation will be touching towards the end. Palliative sedation is the administration of sedative substance at minimal doses necessary to lower the consciousness, and it is a temporary process. It will be done to reduce the refractory symptoms. Next slide, please. Okay, advance directives, a statement made by a person with decision-making capacity, stating his or her wishes regarding how to be treated or not treated at the stage when he or she loses such capacity. Surrogate is a person or persons other than the healthcare providers who is or accepted as a representative of the patients in the best interest, who will make the decisions on behalf of the patient when the patient loses decision-making capacity. Okay, so these are the ethics of medical, and we know all it. Okay, next slide. Autonomy, beneficence, maleficence, and justice. Okay, so the principles involved in end-of-life care is, to provide adequate relief of the suffering and adequately address the physiological and psychosocial symptoms, and provide the social support also. So the principle involved is both for the patient and for the family members. So avoidance of non-beneficial interventions that will harm the patient if we are going to do that. And all patients are entitled for care. So we are not going to send the patient back saying, okay, nothing can be done now, so please take the home and let him survive as long as it. So everyone has to receive symptom management. Everyone has to given the chance to improve the quality of life. So we are not sending anybody back home just like that. So all patients are entitled for care. So even though there is no treatment or management of the disease, but then the care will continue. So that is the principle involved. Next slide, please. Okay, so what is the first thing we need to learn in managing the end of life care is the communication, which is very important. Personally for me, it was difficult because we are not taught this in medical school. Communicating with the patient, we are only taught the managing the disease, how to handle the disease, but then not the patient. So it's all about communication. So it takes a lot of our time when we communicate. Sometimes it takes hours of our time, and we'll be talking the same thing. But then communication is a central pillar in handling the end of life care. So in palliative care, we are taught we have to listen and then talk. Listen and then talk. So we listen more than we talk, and we allow the patient and the family to talk more. Yeah, so how to proceed end of life care? The first thing is prognostication. This is not always very easy, but then it's a skill we need to develop. And I believe most of us are already doing this. Patients ask us, or the relative ask us, how much time I have, how much time my patient has. So what we do is whenever we are confronted with this question, okay, we ask a question back to them. Why do you ask? That is a question we ask them, and basically we want to know, are there any unfinished business? That is the reason they are asking. It's not for any purpose or anything. So they have to take care of their finances, they have to take care of the family. There will be children, some of them they die young, so they have to make a plan for their children. So they ask this question, how much time it has. So prognostication is very important in end of life care. So for most patients, it may be asked to days to weeks. In palliative care, mostly it is asked to days to weeks. Very rare we see patients for months together. Usually for me, the longest patient I had was 2 months, but then most patients come to us towards the end of life, so we handle them just hours to days. How to communicate? If they are in acute crisis, if they are in shifted to ICU, we tell them, okay, unless there is a dramatic improvement in the next such a short time, so we have to tell that time, either it is 24 hours or 48 hours. Then if there is an improvement, then yes, your patient is going to be all right. But then if there is no improvement, then your patient is close to dying. So that is what we tell. The most commonly we used is, okay, we are doing this process, we are doing this intervention. It is good to hope, but also it is best to be prepared for the worst. So we have to prepare the family for the worst. So we should never give a false hope. That is what we are totally against. Let's see, the most common thing, okay, let's wait and see, because there is no much time. So we don't ask them to wait and see. So we tell them, take one day at a time. Okay, we are doing this, let's hope, okay, that this intervention will bring improvement. Otherwise, your patient is close to dying. So we have to prepare them again and again. So this is very common in our practice. We deal with mainly advanced cancer patient. So most often the patient deteriorate and they die eventually. What will happen if we don't prognosticate well? Basically, it will lead to poor symptom management, unnecessary interventions, and poor quality of life towards the end. And patient die with lot of interventions, with lot of pain, with lot of suffering. So prognostication is very important when it comes to end of life care. So recognizing terminal phase is important. Basically, to plan for end of life care planning, it facilitates end of life care planning. It prepares the family and patients and the caregivers, those who are involved in the care. And also it also gives us a platform to discuss about the preferences of end-of-life care. So where the patient want to be cared for, whether it is in the hospital or in the hospices or in the ICU with all the interventions. So it will help us, prognostication. So how do we know that, okay, patient is close to dying? So the couple of symptoms that appear towards the end. So the patient will be drowsy, there will be persistent weight loss, they'll be feeling tired all the time. That is the most common complaint I hear in the end of life. I feel tired all the time, doctor. I eat, but still I feel tired. So weakness and fatigue is a very classical symptom. They don't get out of the bed, they are sleeping most of the time. So they feel weak and tired. Social withdrawal is one more thing. They don't want to meet with people. They don't want to hang out with people. They don't want to meet their family members also. They just, if they are able to mobilize themselves, they come, they eat, and then they go back and sleep. That is what the thing. So slow social withdrawal is also one of the signs. Slowly towards the end, as they are nearing death, they lose interest in their food and drink. So this is a time when family wants to give them everything so that they survive longer, so that they gain energy and they live longer. But then even their choicest food, they don't like it. They say, I don't want. So even if you bring their choicest food, they just eat 1 or 2 bites, they sip just 1 or 2 sips, and they say, enough is enough. So and we deal with a lot of this. Patient complain that, okay, my family is forcing me to eat. But I'm not able to eat. I can't eat. So, but then family says, he is not eating. If he doesn't eat, how he's going to survive? So this is a conflict in the family that happens, and we have to deal with that. We counsel the family members saying, we cannot force feed the patient, because if we force feed, eventually they will have nausea and vomiting. What is happening is the body is preparing to die, actually, because that is what is happening in the end of life. The organs are shrinking, the physiological functions are shrinking, so they are losing their appetite. So if they are overfed, they have nausea and vomiting. So, but then the family force feed. So we counsel, don't force feed. So feed on demand is what we advise the family members. So when they say, okay, I want to eat, okay, let them eat. Otherwise, you can just give them sips of water or a juice. So that should be enough. Dysphagia and difficulty in swallowing medications, that is one more sign, one more symptom. And delirium is one more classical symptom we see towards the end of life. Progressive delirium. Okay, so what are the signs we'll see? There is change in the breathing pattern. There will be tachypnea, there will be breathing hard, they'll be struggling to take their breaths. Then irregular breathing pattern is one more thing. There'll be periods of bradypnea, and patient are with a lot of secretions also. We'll be dealing that with later. So they struggle to breathe. Second change we see is their peripheries are cold. So there is a peripheral vascular shutdown. So their extremities are cold. If you touch their feet, it is mostly cold. And family members say, doctor, whenever I touch his leg or her leg, my patient's leg, it is cold all the time. Is it all right? Yes, it is the sign of end of life, and that is because of the peripheral vascular shutdown towards the end. If they are having liver involvement, especially many of our patients, they have metastatic illnesses, so there will be deepening jaundice if there is liver involvement, so that keeps worsening. So that is one more sign. So observations, what we see is reduced urine output, so the kidneys are shutting down, so there is oliguria, then BP is falling, there's hypotension, and then there is decrease in the oxygen saturation. I lost the slide. And there is also episodes of physiologic hypoglycemia attacks towards the end. This is one more thing I have seen towards the end. Patients going for repeated hypoglycemic attacks. So if it is especially towards last few hours or days, in the last 1 week of life, there will be a persistent hypoglycemia that sets in. And with whatever we do with our dextrose correction, it's still the sugar level doesn't come up. It comes up and then it doesn't stay there. consistently, again, the patient goes in for hypoglycemic attacks. Okay, so when does the palliative care should start? This is a graph which is, explains. So towards the, if you see the left side of the picture there, the blue one is palliative care. So when the person is diagnosed with a serious illness, so the role of palliative care is minimal, because there are chances for interventions, medical treatment, and improving the condition. But then as disease progresses towards the end, the role of curative, which is in purple, you see, it reduces and palliative care increases. So towards the end, it is mostly palliative care. There is no role for curative, because the goal of care is shifted from curing the illness to comfort and supportive. So this is when the end of life care, when they are diagnosed, we have to initially start the disease modifying agents, whatever it is. Either the oncologist will start the chemotherapy or the radiation, and then towards the end, if there is no improvement, there should be more role for the palliative physicians. Okay, so first thing we have seen is prognostication. We have seen the signs and symptoms, how we have to identify the patient is on end of life care. Second thing we need to do is, once we are sure that patient is on end of life care now, so advanced care planning has to be started. So the decisions about next slide. Okay, so decision about a place of care, decision about how it is delivered, decision about which team to involve. Like, is it going to be intensivist in the ICU or oncologist, or it is going to be just palliative? So in India, patients still choose oncology and intensivist, and palliative care is not a big picture even towards the end also, because family are not aware of it, or family wants to do everything till the end. So that trend is still there. So which team to involve in the end of life care, and how much care to deliver, and when to stop our interventions. So, and then a place of death is also important, whether it is going to be home, patient is going to die in hospital, patient is going to be dying in the hospice, or patient is going to die in ICU with all the interventions. So advanced care planning involves all this: place of care, what care, which team, how much, and when to stop, and place of death. So these are all involved. Previous slide, please. So recent amendments, I think we had a discussion last week. I think there were recent amendments by the Supreme Court. So I won't be talking much on this advanced care planning. It is already covered, I believe. But just two things that have changed compared to the last one is, there is no need for the counter signature of the district magistrate, which is a good thing. Otherwise, for everything advanced care planning, we have to visit the magistrate office. The second thing is, even for withdrawal of life support, the hospital will set up 2 committees, and they will decide, the withdrawal of the support. And then there is no need for district collector to be involved henceforth. So these are a big milestone we have achieved in advanced care planning. I think in the days ahead, things are going to improve, and more people are going to make use of this, and patients are going to benefit, and not receive the unnecessary care, unnecessary interventions in the ICU. So second thing is advanced care planning and about resuscitation. Next slide, please. Next. Okay. So whatever it is, we have to document everything. It is very important in end of life care. Even informal conversation has to be summarized and has to be documented in the file, and everyone should, all the caregivers, nurse, the social worker, or the chaplain involved, or the counselor involved. So everyone should be in the same page. So for that, documentation is very important. So we need to document part, or it is the advanced care planning. Of course, it's a must documentation. Next slide. So the third thing we are addressing will be the symptom management. So towards the end of life, there are a couple of symptoms that gain more picture, and that needs to be addressed for improving the quality of life. So a couple of symptoms which are very common in the bedside we see. So that is what we are going to touch upon. Next slide. Okay, the first thing is pain, right? Everyone fears pain, right? So no one wants to die in pain. everyone has the right to die painless, and that is our effort. And in medical profession, this is our effort, so that patient is not in pain. So how do we address pain? Of course, I think all of you are definitely using morphine and fentanyl. So this is the same medication we are using in palliative care also, end of life care also. So strong opioids, morphine and fentanyl. So when the patient comes to us initially, if they are opioids like tramadol, tapentadol, codeine, and buprenorphine, and sometimes adjuvants also NSAIDs. But then towards the end, as disease increases, the pain increases. So they will need a stronger opioid. So they need morphine and fentanyl. So we use either IV or subcutaneous route, which is very common. In palliative, by the time they reach, IV lines are invisible. We cannot access their IV lines. So we use most of our drugs through subcutaneous route, including tramadol, tapentadol, including our nausea vomiting medicines like metoclopramide. So we all use that as subcutaneous route. So efficacy, according to the research, says that it is equal to IV. So we use or IV or transdermal. If they are already on opioid preparation, so we have to convert them into IV form or subcutaneous route. So we start small dose and then slowly we increase. So morphine, that is what most commonly we use. One thing is it is a cheaper option for us, and even those patients who don't have access to fentanyl or who cannot afford fentanyl, so they can have access for morphine, and it is cheaper and they can be painless in the end of life care. So we use morphine very commonly. In current setup where I'm working in Cytecare, fentanyl is mostly used. We use we use transdermal patches. Sometimes if there is an acute pain crisis, we use IV preparations. So syringe driver or continuous infusion is most preferred to tackle the pain. So pain is addressed aggressively in palliative. When the patient lands in either in ER or in OPD, if they are in severe pain, so we treat pain aggressively. So we don't give oral preparations when patient says they are in pain. We start with IV infusion. So, and then if they have a syringe driver, of course, in India, we don't have much use of that. But in the hospice where I worked before, portable syringe drivers were very commonly used. They are just like one, as small as a compass box, and they just fit in the pocket. So medicine will be loaded, and the injection morphine or fentanyl will be going continuously, will be pumped in continuously. So pain, that is how we address morphine and fentanyl, treat it aggressively. Next slide. So we use a WHO pain ladder. We have step 1, step 2, and step 3. So usually in end of life care, step 3 is what we use: strong opioid plus NSAID, like either paracetamol or diclofenac, according to the renal status we use. If they are having renal issues, we don't use strong opioids. We either combine with step 1, which is non-opioid, either paracetamol or maybe paracetamol or buprenorphine, weak opioid, or tapentadol. That is what we use. Yeah. So we have concept called complete pain. So in palliative care, if you see the right side of that, below there is a physical pain. But then that is just one part of the pain, because we are not just seeing the disease or the wound or one organ there. Actually, we are treating the whole person. So there could be a psychological pain, there could be a spiritual pain or existential crisis he might be having. There could be a social pain, the social withdrawal. He's not able to go out and meet. The patient is not able to go out and meet his friends. And so that will all augment or increase his physical pain. So when we address pain in palliative, we address not just an organ or wound, we address a person. So we try to identify the other areas of pain that is contributing to his pain. So we counsel, we involve counselors, psycho-oncologists. So we ask if there is any psychological pain. If there are social workers, we ask, involve them in social work related to social pain, why it is happening, what is the social issue he's having. Maybe it's a financial crisis. Maybe the patient is worried about the family. Maybe a patient is worried about the children, after he dies. So that will all aggravate his pain. So we address all other pain along with the physical pain. So we treat physical pain with drugs, and other things we try to see what we can do for the patient that will relieve his physical pain. So especially spiritual pain is very important towards the end. Existential crisis, is very important to be addressed. Patient have this question, what has been my life about? What I have done? What was the purpose of my life? I have not done anything bad. Why this disease has come to me? So all these questions we need to address to tackle the physical pain. So for that, we need to take help of other specialties. So we need to involve psychologists, we need to involve psycho-oncologists, we need to involve counselors, we need to involve social workers, we need to involve spiritual caregivers, either depending on the patient's religion. So we need to involve chaplains, or the mosque leaders, the spiritual leaders in the mosque or in the temple. The priest has to be involved. Only then his physical pain will come down. That is very common we see in our OPDs, addressing the spiritual, psychological and social pain. And that eventually we see that, when all other things are addressed, his physical pain comes down and his dosage of morphine comes down, his dosage of fentanyl comes down. So it's not just one part we are addressing, we need to address the whole thing. So involve a team. We are not one man show in the palliative. Towards the end of life, we need to involve every other specialty to give the comfort care. Neuropathic pain, initially, if they are conscious and oriented, we can give them orals of gabapentin or pregabalin. Dosage is 100 mg to 400 mg. Pregabalin, it comes in 50-75. I am not very fond of pregabalin because it increases the sedation, and patients are not happy with pregabalin. My patients, usually they are more compliant with gabapentin. So I use more gabapentin in my practice than pregabalin. I use combination medicines with nortriptyline also. So gabapentin with nortriptyline 10 mg or 20 mg. So I combine and I use. If patient is not controlled with gabapentin or pregabalin, we have lignocaine patches. We use IV lignocaine also in a syringe drive, or sometimes methadone is the best option for neuropathic pain, and we have seen a good relief with methadone in those patients who are having a lot of neuropathic pain. In very severe cases, we use ketamine. I have not used so far. My patients have not reached that stage, so much crisis. So I have never used ketamine, but in very extreme cases, for to address neuropathic pain, ketamine is the drug of choice. So breathlessness is second thing we encounter towards the end of life. How do we address? Morphine or equivalent opioid. Mainly morphine I use, a lot of morphine we use. So the dose is different from the pain relief dose. So it's not the same dose. We use half the dose what is used in for the pain relief. So 1 to 2.5 mg every 4 hours, either subcutaneous or IV, and it gives a very good pain relief. What morphine does is it decreases the respiratory rate and increases the end expiratory capacity. So patient, that sense of panting for water, that struggle, it eases. So patient feel better with morphine. I have an elderly patient even now who is 95-year-old. His main complaint is breathlessness. He doesn't have any disease, but then he struggles to breathe. So I just added 5 mg of morphine thrice daily. He's 95. I was very careful in titrating his dose. Initially started with very small 2.5. Morphine is very small tablet. It was very difficult to break, but then I didn't want to make this patient drowsy. So I started with 2.5, but then even with 2.5 dose, TIT dose, thrice daily, he had breathlessness. So I increased the dose to 5 mg. So currently he's on 5 mg 3 times daily, and patient is very comfortable. He's not drowsy, and his breathlessness has come down very significantly. So even yesterday he was here, and he was breathing so fine. So morphine is the drug of choice we use in palliative for breathlessness. If it is a lot of lung involvement, lung meds, we use it as continuous infusion. So either they admit here with us in the ward, or we give them oral preparations. If they are drowsy, delirious, and unconscious, then we admit the patient and give morphine IV. Otherwise, it's a oral preparation. So dose is usually 20 to 30. We need to be careful when we add this medicine in elderlies. So we add the smallest dose and then titrate accordingly. So the usual dose is 20 to 30 mg of morphine sulfate per day. So either in syringe drive or in syringe pump. Breathlessness is often accompanied by anxiety. When patient is breathless, so he's very anxious. So we use combination of morphine and midas if it's an acute crisis, either in syringe drive or IV continuous infusion. What I do is I combine 20 mg of 20 to 30 mg of morphine along with midazolam, and I give it as a continuous infusion in a day. So that relieves the breathlessness, anxiety. So once the anxiety comes down, I stop midazolam and then I continue only the morphine. So acute crisis, we combine morphine and midazolam. Nausea, vomiting, if prokinetic action is required for nausea, vomiting, then we use metoclopramide, which is our perinom, which is most commonly this one used. Dose is 10 to 20 milligrams thrice daily, or if it is required more, then we use 4 times also. And if you are using in syringe drive or syringe pump, we can combine the whole thing. We can give up to 30 to 80 mg according to the symptom. One more thing, what I learned in palliative care is, using antipsychotic like haloperidol as antiemetic. So haloperidol in low doses acts as antiemetic. So centrally acting drug haloperidol, 0.5 to 1.5 mg we use, especially patients with liver metastasis. When there is rise in bilirubin, they have a lot of nausea and vomiting. So we use a lot of haloperidol to treat nausea and vomiting. Other medicines actually are cyclizine and levomeprazole are not very commonly used. They are not used in Indian setup. So haloperidol and metoclopramide are most commonly used. Haloperidol can be given up to 5 to 15 mg as a continuous infusion also. So if there is obstruction also, okay, yeah, thank you. Next, yeah. So if there is an additional gastrointestinal obstruction, so along with colicky pain, so we use combined haloperidol along with hyoscine bromide, buscopan, so 20 to 40 mg, or it can go up to 240 mg per day in syringe drive. So I have not used such a high dose, but then with 60 to 80 mg of hyoscine, I have achieved good pain relief for my patients with intestinal obstruction. So along with, if there is refractory vomiting, either haloperidol we can use, or the drug of choice would be octreotide at 100 to 300 micrograms. I've used it on 2-3 patients as a continuous infusion. Last year I had to use, so I used around 300. At 300 the patient didn't settle, so I used it as a continuous infusion. I didn't go, literature says 1200 mg in 24 hours, but then I have not used such a high dose. I've used close to 600 mg max. So, and I have achieved good symptom relief in patients with obstruction. Also, ranitidine can be used 50 mg TDS, or if you're using a continuous infusion, so 150 to 200 milligrams of ranitidine can be used. So terminal restlessness, agitation, or refractory delirium. So this is one of the most common we see just few hours before death. So patients are restless, and family seeing the patient restless, family is restless. So it's a very difficult situation to handle, but we can achieve good symptom relief using antipsychotic haloperidol again at 1.5 to 5 mg thrice daily dose, or best option is give it as a continuous infusion, 15 mg per day max we can. I have used, and it has given good symptom relief. So other medicines I have used is olanzapine, 2.5 to 10 mg per day, and then levomeprazole and chlorpromazine HCl, I have not used, and I don't think it's available in Indian setup. But then wherever I have worked, I've used olanzapine and haloperidol to treat terminal agitation. Benzodiazepines has to be combined to achieve initial symptom relief. Midazolam at 2.5 to 5 mg every 4 hours you can use to calm the patient down. Clonazepam is one more option, but then we don't use much. Dose is 0.5 to 1 mg. So I not use clonazepam in syringe drive also. So what I use, the best cocktail is morphine plus midazolam and haloperidol. So I combine morphine 45 mg plus 5 mg of midazolam plus 5 mg of haloperidol, and I start infusion at 1.5 to 2 ml per hour and slowly titrate according to patient's comfort. So this gives me good pain relief. It gives me anxiolytic. It reduces the breathlessness, and haloperidol, it reduces the terminal agitation and restlessness. So this is usually I start the patient just few hours before death. So maybe patient are going to die in a day or two, and patient is very restless. So I start this infusion. I tell my team, the nurse involved, I tell the psycho-oncologist that, okay, I'm going to start this patient with palliative sedation. We'll cover this in the end. And then we start this infusion, and patient, they die, they are sedated, and the natural process of death takes over, but then patient is comfortable. Patient is painless. There is no groaning or moaning. So patient is calm. So even the family is calm. Family is happy, seeing the patient, calm. So this is the best cocktail I have used, and we use it very often in palliative. So respiratory secretions are also common. So towards the end of life, what we call is death rattle, where the secretions are pooled in the throat area, and then during expiration, that throat secretions, they combine with this expiration, and they cause this gurgling sound, and then which is very actually disturbing for the family. Family comes and asks, is my patient restless? We see that, we hear that sound. But then actually patient, if you are already on, patient is on sedation, patient is not restless actually. So it's just that, the sound that comes. So how do we treat it? We use hyoscine 0.4 every 2 hours or 4 hours, or continuous infusion we use, or other option is glycopyrrolate 0.2 to 0.4 mg every 2 to 4 hours according to the symptoms. So what I use is in a syringe pump, continuous infusion 10 to 20 mg of hyoscine butyl bromide in 24 hours, and I see good reduction in respiratory secretions, and even the death rattle comes down. Other thing we need to do is turn the patient to the side, so and allow the gravity to take over the secretions, and secretions are we can use suction, but sometimes suction can be disturbing for the patient. If I have seen with suction a patient with the brain metastasis, when we did suctioning, a patient started seizuring. So we should be very careful when we do suctioning. So if there are patients with brain involvement, they can seizure just with suctioning. So to avoid that, just turn the patient to the left side or the right side, and then the secretions are seeping out. Seizures, very common, we see in brain mets patient, like I said. So acute crisis, we use midazolam, either subcutaneous IV or buccal 2.5 10 mg start or continuous. So in 24 hours we use 10 to 20 maintenance for seizure prevention. Clonazepam is one more option we use, but then most commonly we use midas. We have midazolam sprays also, nasal sprays. So we have used midas spray on patients recently with meningeal mets. So she was seizuring continuously. So IV, she was little obese side, IV lines were not accessible, and even the subcutaneous was not helping much. So we used midazolam spray, and with that there were good symptom relief towards the end of life. So midazolam is good thing. If midazolam is not working, then the next option would be our barbiturates, like phenobarbital infusion. We will cover this in towards the end in the couple of slides. So hemorrhage is one more common symptom we need to address, especially head and neck cancers. lot of metastasis in the neck. There are big vessels there, so we need to address bleeding. So what we use is, we don't use any medicine to control the bleeding. If it is cancer patient having a hemorrhage, very rarely it addresses to it, obeys tranexamic acid, but then midazolam is what we use. We sedate the patient. So I had this one patient in the hospice, extensive neck metastasis, all the nodes were involved. There was a tumor sitting on the carotid. So I finished, it was on a Sunday rounds, I finished seeing the patient, and then I just went to the next ward, and immediately the nurses called me saying the patient has started to bleed. I knew it was a carotid blowout. By the time I come, it was just 15 or 20 seconds, because I was just there. By the time I come back, patient had already died. So it is going to be a massive bleed, and then patient is going to die eventually. So what we need to do is, we have to sedate the patient. So we give midazolam 2 mg or 4 mg. We sedate the patient, and we try to apply pressure and see if the bleeding can stop. And we have to be with the patient. Don't run away from the patient when the patient is bleeding. Just stand next to the patient and hold the patient hands. So that is very important. And usually it will last few minutes, and usually it will be terminal, and patient will die eventually. So never leave a patient when patient is bleeding, because they have that sinking feeling. So nurse has to sedate the patient while you stand there, and then just hold hands and just be with the patient. If it is the wound bleed, we have used tranexamic acid 500 mg or 1 gram IV. Sometimes we have sprayed the injections over the wound to control the bleed, but then it's a yes or no. There is no literature in support for that. But then we have seen few bleeders to obey the tranexamic acid, and they have controlled the bleeding. Otherwise, usually it is massive towards the end. Okay, so this is very important towards the end. When we have done all that, we have tried to control all our symptoms: pain, breathlessness, seizures, nausea, vomiting, but still, patient is not relieved of the symptoms. So what we do? So we do palliative sedation. So it is towards the end of life, to control the symptom, to control the refractory suffering. So when to consider, when severe symptoms, pain, vomiting is increasing, and patient is restless, patient is in distress. So there are seizures, and there is delirium, there is anxiety, there is depression. So when our conventional treatment doesn't work on the patient, so we need to consider palliative sedation. So what we do is, we sedate the patient. We don't make the patient unconscious, right? So we need to identify the difference in both. So palliative sedation is to cause a deep sedation and not cause unconsciousness. So sometimes it is mistaken for euthanasia. Whenever we had this, when I was working in hospice, so when symptoms were not controlled, we used to start this palliative sedation towards the end. But then there was this rumor going around that, okay, when patients are dying, the doctors do euthanasia because they start this. But then we had to educate the families, we had to educate the nurses among those who are working there, because they didn't know about deep palliative sedation. So they thought, okay, once we start the sedation, patient dies immediately. But then we had to educate, and we have to tell them that it's a sedation. It's not euthanasia. So there is a difference there. So deep palliative sedation, or otherwise called sedation to unconscious or continuous deep sedation. So many nomenclatures we have. So designated controlled induction of sedation to unconscious to relieve severe suffering in dying patient. So that is what the goal is. Next slide. So how deep sedation is not equal to euthanasia. So is it equal? It's no, it's not equal. But how it is not? So the intentions are different. So in deep sedation, the intention is to comfort the patient. Intention is to control the symptom. Intention is to improve the quality of life. So the intention is not to hasten death. But in euthanasia, the intention is to hasten death. In palliative sedation, we are not hastening death, but then we are trying to control the symptom. So in practice, deep sedation involves a titration of medicines to achieve the goal, which is comfort. So once that we reach our goal, which is comfort of the patient, then we reduce the dose to the lowest dose that maintains that comfort of the patient. So we are reducing the dose. But then in euthanasia, it's not like that. We are trying to hasten death and we are increasing the dose continuously. So intention matters, whether it is comfort or death. So before we do that, we need to, there are some prerequisites. We need to do certain things. Okay, next slide. Okay, so indications, like I mentioned, very severe chronic, suffering from severe physical neuropsychiatric symptoms. The goal is comfort. And we need to have, do not resuscitate or advanced communication in place. No, do not intubate. We need to have that order in place. I cannot start a patient on palliative sedation who does not have this in place, who does not have that advanced communication in place, who does not have this DNR paper signed in either the patient or the family. So I cannot start this on patient. So we need to educate, we need to counsel the family, we need to, if possible, talk to the patient, beforehand. So all this comes in advanced communication. So this patient is going for the fracture symptom. So we need to have that order in place. Only then I can start. So informed consent is very important. So we have to take signature when you start palliative sedation. And everyone who is involved in the care, of the patient, they have to know, okay, patient has reached a time when he requires palliative sedation. So all the staff members, all the specialties who are involved in the care has to be informed when you start palliative sedation. So the nurses, the counselors, everyone has to be involved. So, and also we have to be mindful of the institutional policies. They may vary from institution to institution, hospital where you work. So we need to get those policies in place before we start palliative sedation. Next slide. Okay, so what we use, we have opioids, again, morphine and fentanyl. We have benzodiazepines, midazolam, our antipsychotic, haloperidol, and barbiturates. We have phenobarbital. Okay, next slide. So what I use, palliative sedation. So I combine morphine sulfate 45 mg plus 5 mg of midazolam plus 5 haloperidol. I mentioned this previously also. So I started as a continuous 24-hour infusion. I start at low dose, 2 ml per hour, and then slowly I increase and I titrate according to patient comfort. So I've gone up till 5 ml per hour. Sometimes instead of morphine, we start, if patient is having renal issues, I start him on fentanyl. Fentanyl, we use 10 ml of 10 ml vial in 40 ml plus midazolam plus haloperidol, and we start at 2 ml or 2.5 ml per hour. So that is what we use. But I prefer morphine sulfate because it gives good pain relief. It gives good sedation to the patient. Or it take care of the breathlessness also. So I prefer morphine, midazolam, and haloperidol combination. Sometimes this combination doesn't work. At that time, we have used phenobarbital infusion also. So I had this one patient with refractory seizures. Seizures were not controlled with anything. So for that, we had to start on terminal sedation. We started phenobarb infusion for her. She was a case with carcinoma breast with brain metastasis. Started with 400 mg, and then slowly we went up till 800 mg in 24 hours infusion. So with that dose, she was calm. There were no seizures. There was no restlessness. So we were able to achieve good symptom control with phenobarb. But then I have not used it very often. So high doses of phenobarbital can result in general anesthesia. I think we all know that. So usually preferred is opioids plus benzodiazepines plus antipsychotic. That is what we use. So terminal sedation, palliative sedation we use when patient is having refractory symptoms. Right, next slide. I think there are a couple of requests for futile interventions. So is more and how much is less, and also, is it time to withdraw or limit our interventions? There's a separate topic on withholding and withdrawal of treatment. I think we can cover it next time if it is okay. So, I think I can end my slide here.
Yeah, thanks, Sandeep, for the talk. Sorry. Personally, we do talk about end of life. We do talk about palliation a lot. But when it actually comes to do the end of life care or care of the dying, the most frequent challenge which we face is breathlessness, and they get agitated and restless. So those are the two very frequent challenge. They start to get gasping. They say intubate the patient, don't intubate the patient. The challenges come in at that point. Patient gets family gets agitated, patient gets breathless. So that would be the point where we would actually reach an impasse. We don't know what to do. Can we give morphine? Like you said, it may end up saying you're killing the patient by giving something which sedates the patient. But the list of medications which can be given and can be done was actually beneficial. That's what I thought. Thanks.
I think welcome. So see, it all starts with communication. From the beginning, when the patient lands in crisis, if you are communicating well, if you are honest, and we need to pass on the information correctly, when you gain that trust from the family. So at that time, when you gain that trust, whatever you tell, the family will oblige. But then if you just, come like one guest appearance, talk few sentences and go back, you'll not gain that trust, and, there will be a lot of doubts. So, we need to listen more on what are their values, what is their query, what are their fears. Then we can achieve all these things. So even for us also, sometimes, when we are introduced to the patient towards the end. So it takes for us a couple of days to develop the rapport and build the trust itself. So what we have seen is when the time limit is less, patient is actually dying in another couple of hours, whatever we are saying, family is doubting. So we have not gained that trust. So gaining trust is very important to achieve good symptom control and, manage the agitation.
I have a question before Shashi talks. The common statements we hear from family is the patient wants to die at home. That's his wish. So we want to take him home. But what we have seen in end of life, we have seen in these many patients is when they reach the stage when he gets gasping and breathless, family gets agitated. And we are not there to take care of this with the medications you mentioned. If the patient is going home for his last few minutes or hours he has, is there anything we can do to ease his discomfort and pain? Is there any such medication list, or is there any such pathway you can utilize so that the patient doesn't die in discomfort at his home?
Yeah, we faced a lot of this, especially for village patients. They want to take the patient home. So what we do is we identify someone in the family who is bold enough, or we ask if there is any nurse nearby your home. Okay, so we the institution where I was working before, they had a palliative team, and they were giving loaded syringes with morphine and midazolam. So we use the subcutaneous route, to inject. So we used to educate the family members, we empower them, and we teach them. So in case patient is groaning or moaning or is in severe pain, this is what we need to do. Give it like an insulin syringe. So 2 ml. So all that order will, but then we need to identify someone in the family who is capable to manage this. Usually subcutaneous route works best, and actually we have achieved this in a very remote village also, where an uneducated person was trained to give subcutaneous, because it's like giving an insulin, taking an insulin. So A patient was with brain meds and there were a lot of agitation and restlessness, but a family member who was not educated was able to give midazolam towards the end and calm the patient down. So according to the institution policy, we can give loaded syringes actually. And label the syringe, mention it, everything in place. Or if they are not educated, we color code and we send them, okay, this color is for this color is for this. And that's the first thing. Second thing is we need to be available for them all the time. So if they are going home, if one of my patient is going home, I give my phone number because I don't know when the crisis appears. It could be middle of the night. So as a palliative care physician, I should be available 24/7. So we need to give our phone numbers, and they will call. Definitely they will call. I receive couple of calls every day actually in the night. What to do. So if it is possible, I direct them, can be managed at home, but then sometimes I tell them, okay, you bring them to emergency. So empowering and being available for them.
Thanks, Sandeep. Thanks.
Yeah.
Shashi?
No, thank you, Sandeep. That was very good. And I think it's when we think of palliation, it's not only about people who definitely have to die, because as you showed in the graph, the palliation starts from the time crisis starts. There are a few things I just wanted to understand. See, one of the things you told us about feeds and losing appetite, and it's not only for cancer patients, isn't it? It's also for most other things. People may end up losing their appetite and having an end stage, for example, respiratory, heart or kidney disease, and irreversible, like treatment options have failed. And is palliative treatment going to be a similar approach in these patients? Because pain may not be a thing, and as you were mentioning, for respiratory, morphine is one of the best drugs for reducing symptoms. Do we take the same approach in all these, or there's going to be slightly different when they're in hospitals and when they're outside?
I think for us as palliative care team, it's the same approach whether they are in the hospital, because they will be seeing us eventually again if there is an acute crisis. So for breathlessness, morphine is what I use, even if it is renal dysfunction, because in one of the definitions, I skipped that slide. It says principle of double effect, where my intervention is intended for something else, but then it has other phase of that, which is it is going to harm. Like morphine, if I give, it will control the breathlessness, but eventually it is going to worsen the kidney renal dysfunction. So I have to balance it, and my intention at that time is to control breathlessness. If it is end of life, then definitely I would focus on breathlessness. So the intention and the goal of care, which is comfort, I can achieve it only by giving morphine. If I don't give, maybe I'm preserving the renal function, but then patient is restless. So I would choose to still give morphine, even though patient is with renal dysfunction. So that is how. Yeah.
There's one more hand raised. I've got one more question. Swarna, you can ask a question.
Sandeep.
Hi, Dr.
Beautiful presentation, Swarna here. I'm a renal physician, and I think it's a good concept to penetrate into our system. I think, which is still a baby. Yeah. So I have a comment, and I have another question for you.
Yes, please.
One, I think many times we make patients as if CKD stage 5s, we make patients as not for dialysis. We do that. It's not everyone who goes into CKD should go on to dialysis. And what I've seen is I use the word supportive care. I refer to palliative. Sometimes I have some expertise. I wouldn't call myself being as great as you, but still they like the word as supportive care than end of life care, because as soon as I use the word end of life, they get, oh, they don't like that. So supportive care, and I think still their itching is a big problem, breathlessness is a big problem, and I think some of these things we use. And the other thing is the primary physician not leaving the hand is primary thing, I think, because as soon as we handball to palliative, many times because we are not, it's essentially, oh, our palliative, I don't need to see. I think then family starts, there's a sort of separation anxiety because we have maintained that relationship for a long time. So primary physician, although not doing much, but still hand-holding is thing which I've observed, which helps a lot in keeping the family quite comfortable. This is my comment. And second comment is hydromorphone available in India?
Thank you, ma'am, for that comment. I totally agree with you. Primary physicians still continue to have a role even in end of life. At least they have to come and visit the patient. See, most of the time what happens is it's like a handover. Okay, from now on, so and so palliative doctor will see you. And like you mentioned, that separation anxiety, that is one thing. And second thing is abandonment. Most of the time when patient land in our OPD, they are very upset. They feel abandoned. But then we need to counsel, we tell the patient, okay, what really happened, the progression of the disease and all that. But then this is one part we do. Second part, what we do is we go and talk to the primary physicians and tell them, you please continue to visit the patient. Maybe you're not giving any active treatment, but at least come and, show your face because they like your face. They're attached to you. So, we tell them, okay, you please continue to see, even though we are doing the interventions now, whatever the supportive care, but then you please come and, just, few seconds, if you come and just inquire, okay, how are you doing? That's enough for the patient. So we tell the primary team, which is involved from the beginning also to, continue the care, at least the visits. And second part, hydromorphine, we don't have. So we have morphine sulfate, immediate release, sustained release. So in different preparations.
Okay. Thank you so much.
Welcome.
That was a beautiful presentation.
Thank you. Thank
you. If no one else has any questions, thank you very much, Sandeep, for.
Thank you, Dr. Sheshan. I'm left with the request for the futile treatment, and I'm left with withdrawal and withholding treatment. So I'll be covering maybe sometime,
in a few weeks time we will reschedule this. So there's some, great. Thank you very much.
Yeah, welcome.
Thank you.
Thank you all for it was wonderful meeting you all here.